because we are actually behind the schedule. So I would like to introduce our second eminent speaker, Dr. William Burdek. Dr. Burdek is a graduate of Oberlin College, Weill Cornell University College of Medicine, and the University of Pennsylvania. He completed residency training in internal medicine and is certified by American Board of Emergency Medicine and American Board of Internal Medicine. As the former Vice President of Education at FEMR, he was responsible for creation of global faculty development programs for health professions educators. He has received multiple awards for excellence in teaching. Dr. Burdek is the Vice Secretary General of the Network Towards Unity for Health, an organization of community-oriented health professions school, and Professor of Emergency Medicine at Thomas Jefferson University in Philadelphia. Dr. Burdek, he will talk today about proactive and reactive medical education in time of crisis. Dr. Burdek, the mic is yours.
Thank you very much, and it's a real pleasure to be here, and I appreciate so much the invitation. It's really an honor to follow you, Gary. I realize that I am standing here at the halfway point between two of your previous appointments, halfway between University of the Sciences and Thomas Jefferson University in lovely downtown Philadelphia. So it's fun to make that connection. And I also really appreciate the previous speakers, and I had the opportunity to listen to several of them. Some were, of course, too early for me. So what am I hoping to do today? We've heard a lot about how we've reacted to the pandemic crisis, and so I will start with that, but with a focus on how the reactions that we had were challenged and limited, and they had problems. And then I'll pivot to changes in medical education that will help us to anticipate the next crisis. And many of the concepts were touched on by the speaker on academic development, Gary's lovely talk on leadership, Dr. Rania's talk on student reaction. So you'll hear some echoes, but I'll try to build on those concepts as we go along. So we all know that we had a major pivot to online learning. We had lectures, discussions, examinations, all moving to online. And I'm putting online in quotes, you'll see in a moment, using that term somewhat advisedly. We had telemedicine for practitioners, and occasionally, but not often, there was a limited student role. There were some alternative student activities. One creative university had students reviewing emerging COVID research. And as Dr. Rania pointed out, there were some remote simulated patient interactions. What we learned is that although many could connect, connectivity is often a limiting factor. And that's just as true in a high resource place like the United States as it is in a low resource place in other parts of the world. And I'm going to talk about that inequality as an important factor moving forward. We also, and again, Dr. Rania pointed this out, or her students pointed this out, online requires greater interaction to maintain engagement. You have to have periodic breakouts, you need all-inclusive systematic report outs, you need to have cameras on, otherwise you never know what's going on behind that little black screen. We know that students and learners in general who are online are easily distracted. There's so many other things going on in our environment, so it's necessary to limit the length of those sessions. And we also learned that while you can have a live session at the center of educational design, you need to have a continuum with a pre-live session, opportunity for something, either readings or reflections, and then a post-live session follow-up, either online discussion or assignments. We also learned that this stuff takes time and resources. The faculty initially just stood in front of a microphone and camera and just gave their lecture. But what we understand is that it really takes some time to design effective structure and to create effective content for online faculty. That takes faculty development. But we also learned that the infrastructure needs to be improved. Internet connectivity, electricity, electrical grid, cameras, lights, microphones. Those were often limiting factors for students in many parts of the world, including the United States. So why do we need to wait for a crisis to make some changes? We now understand, and we need to teach those factors that correlate with preparedness. We need to look for ways to be more adaptable to changing needs, and we need to recognize the societal factors that affect our response in general to crises. One of the key factors that I think we don't consider enough, and I haven't heard much discussion about recently, is something that was the focus of a Lancet paper I would say last month, but a couple of weeks ago, where they have there's a national preparedness collaboration with hundreds of countries involved, and they looked at all of the factors that they could consider against the dependent variable of pandemic readiness, and one of the metrics for that was percentage of vaccinated populations. And surprisingly, what they found was not the economic level of the country, not the number of pharmaceutical companies or the amount of health care that they had, but rather the level of trust in the society. Trust in government, interpersonal trust, and inversely proportionate governmental corruption. And this is a chart of all of the factors that you can find in that paper, but what they really noticed that was significant was more corruption, lower preparedness, decreased trust, lower preparedness as well. And trust is not something that we talk about very frequently. There's a fascinating book, The Spirit Level, by Wilkinson and Pickett, that correlates trust with economic inequity across, oh gosh, maybe 20 different factors, different outcomes. Each chapter has a different outcome. And in the lower left corner, you can see just one of their many charts. These, by the way, are freely available online, where the level of economic inequity, when it's high, the proportion of people that you trust, or the amount of trust that you have, is low. High inequity, low trust. And I'll just frankly point out the United States is in the high inequity, low trust quadrant. What are the implications for education? My good friend, Professor El Hassan, talked about the social determinants of health, but I think we need to add trust as a major factor in this discussion of social determinants. I think the health profession school, they do have a role in society to advocate for equity. They do have a role to support people in lower socioeconomic stratas. Those aspects can also be supplemented with explicit teaching of trust. We want to strengthen our public health teaching to include the relevance of social factors in policy adherence, and one of those social factors is trust. We, as members of universities, have many interactions with communities. Let's be explicit in advocating and promoting programs that foster trust. And then in teaching and trust, there are many paradigms, many models for trust, and there's a lovely website that I've got in the corner there that'll give you a couple of dozen more paradigms for trust. But the one that I like is trust as four things: integrity, which is doing what you say you're going to do; predictability, which is the ability to anticipate the other's actions; delayed reciprocity, which is giving without immediate expectation for payback; and exposed vulnerability, which is revealing deficiencies in yourself with the expectation that the other party will not take advantage. So those are that's a 4-point model for trust. Many other models exist. It's a nice one because it's simple and it's easy to relate to. By the way, the delayed reciprocity one is relevant to one of an author, Adam Grant, wrote a nice book called Give and Take, in which he talks very frankly about givers and takers. And so delayed reciprocity is a prime factor or feature of givers. Now, in order to be proactive, I've partitioned the proactive response into 3 areas. One is the development response process development, and Gary's talked about leadership, as have others, but also I want to add program evaluation and the concept of connectivity, all aspects of what I'll call response process. The other is delivery, the online presentation of preclinical stuff. I'll talk about that. And then finally, I'll talk just a bit about content. There's some aspects of content that I think we really need to think honestly and frankly about in terms of prevention, in terms of social elements of health, and in terms of changing healthcare. As Gary has just talked about, to adapt to crises, we need to strengthen leadership skills. I've sort of boiled the key leadership attributes to communication, preparation, resilience, and reflection. And as Gary pointed out, communication is mostly about listening. As an Indian colleague of mine used to say, we have 2 ears and 1 mouth for a reason. And there are many examples of great leadership that involves great listening and involves great involvement of the people that we're trying to lead. And the second attribute is preparation, being sort of knowing more than you need to know. Resilience is a function of being able to bounce back after adversity. And one of the interesting points that I heard Gary talk about is how, I know it was the first speaker, reaching out to others who were not such close connections. I think in one sense, Gary talked about them as ghost leadership. They're out there, but I would take that concept a tiny bit further in terms of resilience and say, and this is something, again, that Adam Grant has pointed out, resilience has a lot to do with your social network, but particularly about your social network that is a low density social network. That is the people who are at a distance, literally and figuratively, from you, but who know you, and they are living a different reality, and they can offer a fresh perspective and help you bounce back better. Reflection is a sense of being self-aware, understanding what's working and what's not working. And I believe that these sorts of leadership skills need to be added to faculty development. Now, one of the things that I believe leadership needs to involve is the ability of leaders to create an environment of sharing, an environment of openness to new ideas. They literally need to create the time and space for that. We've talked about listening. There needs to be respect for new ideas, and again, that element of trust. Parker Palmer has an entire chapter on developing a community of educators in this lovely book that was written, gosh, what was it, maybe 30, 40 years ago, with about 11 editions, 10 editions since then. Take a look at this. I mean, there's a lot more to education and leadership than we've talked about today. And if you want to walk away with something, some little bit of homework, take a look at this book. The chapter on community is towards the end, but I really recommend it. Another book that I think is important to think about that we haven't talked too much about is Brene Brown's book, Dare to Lead, and she talks about 2 functions that are not commonly mentioned, that is courage and vulnerability. The vulnerability aspect is a little bit related to exposed vulnerability that we've talked about with the model of trust. But she has a lot of nice TED Talks if you want to take the 18-minute version. But take a look. She's got a nice writing style. And again, it's a little bit of homework for those of us that are thinking about leadership. And then finally, on the leadership realm, Gary mentioned the stress and the tension involved with leadership. Ron Heifetz is a former psychiatrist who's at the Harvard Business School, and he devotes an entire section to anxiety and how change creates anxiety. The expression that I like is change is good, you go first. Same concept as Gary was talking about. But I do think that the other concept that Heifetz talks about is leadership without authority. And that means that there are many within an ecosystem who can exert leadership, whether it's the ghost leaders, which is sort of a negative connotation, or whether it's student leaders or others who are influencers. And I think that expanding our notion of teaching leadership skills to everyone is probably beneficial for the institutional ecosystem, other staff as well. So that's enough about leadership. I think that there's an opportunity for us also to rethink the way we do program evaluation. Typically, we have a summative assessment at a given point, and we say, oh, you didn't do this, or you didn't do that, or we achieved this or that. I think more frequent, more complete data collection, so-called short loop feedback, including a wider range of stakeholders, educators, learners, the public, including health indicators. Asking the questions, of course, are we achieving outcomes? And again, it's outcomes, not outputs. Outputs are things you can count. Outcomes are impact. Where are our strengths? Where are the gaps? Continuously collecting data, reviewing, and revising in an ongoing fashion. And I think that adding this skill set of continuous evaluation through this process, I think is something that all of the members of our community would benefit from, and their increased knowledge about this sort of continuous program evaluation will benefit the institution. So we do teach program evaluation to a subset of our staff. I think teaching it to a broader range will be beneficial as well. Now, you can say, well, institutions, we don't have much to do with this infrastructure business, but I think that's not entirely true. Institutions, first of all, have lots of resources in general, and they certainly are able to strengthen their own internet connectivity network. So that's an easy one. But I think they also have, at many levels, ministerial levels and intra-university levels, connections with energy and telecommunications sectors. And I think promoting the innovative use of internet connectivity technologies and promoting innovative electrical grids in many parts of the world. This is a huge factor. And I just mentioned solar microgrids because that's one of the functions that has been very successfully deployed in many parts of the world. It's not just about having a computer, or even not just about having an internet connection, but if you don't have a stable electrical power source, you're out of luck. Now, if you want to get a little bit counterculture or iconoclastic, take a look at this piece by Zeke Emanuel. Ezekiel Emanuel was President Obama's chief advisor on developing the Affordable Care Act, and he's now vice provost at the University of Pennsylvania, right around the corner from me. And he wrote a provocative piece a couple of years ago talking about the end of preclinical classroom instruction, the end of preclinical classroom instruction. And what he points out is something that I think we are all aware of, but just a little bit nervous about embracing. And that is, there are incredibly good lectures, images, articles available to all from anywhere in the world. So that one of the examples that he gives in his paper is this site pathoma.com. You can get a 1-month free subscription, and even when you buy the subscription, it's I don't know, it's maybe 75 US per year. It's relatively inexpensive. The lectures are fantastic. And of course, if you don't understand something, you can play it again and again. Images are available on every single aspect of pathology. So that's just one example of how the stuff that we present, the content that we present in the so-called preclinical arena, so preclinical classroom, is totally available online. Now, is that to say that we can shift the entire preclinical instruction to online? Zeke Emanuel would say yes. I think that we need to supplement that, complement that with well-designed discussions, well-designed online discussions if we choose, or in post-pandemic, in-class discussions. And I think that the era of sort of stand and deliver lectures is really a function of the past. And I think that almost any topic, it'd be interesting to see if anyone can come up with topics that aren't covered, almost any topic can be a good presentation about that topic, probably, arguably, better than you and I can do, is able to be found online at a very limited cost. Now, is this really, really threatening to universities? You bet. However, Zeke Emanuel goes on to say that the medical school's key value is organizing and overseeing clinical education, and where there's simulations, interpersonal skills, for example, and procedures, all sorts of things still need to be managed and organized by the medical school. Of course, the connection and interaction with patients and communities is critical. He goes on to suggest that even the clinical years, so-called clinical years of medical school, and residency or postgraduate education ought to be combined. So those are elements that are probably not going to happen anytime soon, but they certainly challenge our thinking about this. And it just reminds me of an element of sort of being creative and being willing to think in alternative ways that suggests that sometimes we need people on our team, people that we get along well with, who might be described as disagreeable. Disagreeable in the sense that they're really willing to offer different sorts of ideas. We might even call them argumentative, but they do so with sort of a loving kindness. But there's a real place for the argumentative, for the disagreeable, as we try to reimagine medical education. We mentioned a couple of times the learning management platform. I have a little bit of a beef with the current systems. I mean, there's often a need to better balance between features and ease of use. And we love some of the features, tracking, students, discussion boards, assessment, but sometimes there are too many of them, and they end up making the platform confusing or hard to use, particularly in terms of authoring, in terms of notifications and alerts, and sometimes the mobile versions are inadequate. So I think there's work to be done here, and I think we can be proactive in that as well. Now, and this takes me to the last area, and that is curriculum. I think there are things that we need to add to be proactive before the next crisis. I think we need to do more on public health, more on the transmission, environmental factors, nutritional factors in terms of prevention of disease. And as Mohammed Al-Hassan talked about, there's elements we call social accountability, but let's make sure that we're also teaching our students all of the elements of social accountability, all of the social determinants of health, housing, green space, or in some cases blue space or open space, and this notion of inequity and its relationship to trust. And I think that the other aspect of trust is having a bit of the education just specifically about vaccine mobilization, which is so connected to trust. We need to develop communication skills, distribution skills, the ability to mobilize personnel. So I think teaching readiness for mobilization, vaccine mobilization, is another element of our public health program and curriculum that I think can be added and should be added. The healthcare system, as Dr. Rania pointed out, is changing. There's a lovely term that I came across called web-side manner. As we move to telemedicine, we need to understand what the advantages and what the limitations are, how to do consultations, how to do guided procedures and transmitted images. But further to that point, there's also artificial intelligence software that's coming in now. Certainly in Gary's field of radiology, there's been a tremendous amount of effort there. Management tools, decision-making tools. There's also a whole flurry of bedside diagnostic tools, handheld ultrasounds, bedside chemistries, PCRs. That's got to be part of our, as we move the curriculum forward. And then there's the electronic health record and how to use that, teaching students how to use that to better communicate, to do quality improvement, and to integrate with artificial intelligence. My generation has reacted to the electronic health record sort of with horror, anxiety, and in some cases depression. I think the next generation is growing up with it, and we need to show that group of young professionals how to use it most effectively. Now, you can't just add, you have to take away. And I think this part of pruning as part of the growth process for institutions and the curricula is critical, but painful. Everybody, most people in the faculty have an emotional and perhaps even a financial stake in teaching some things. But as I have traveled around the world and looked at various curriculum, there are procedures and things being taught that haven't been done for, I'll generously say a decade, but in some cases decades. Chemistries, microscopic stuff, some physical exam things, some surgical techniques. So they need to be deleted. They're drugs that probably don't teach us anything generic, that just need to be removed. Rare clinical entities that really are not a function of the public health landscape, and may not even be, we like to teach rare but life-threatening. They may not even be life-threatening, they're just rare. And you know probably better than I do some of the other things that are in the curriculum that really are hard to get out, but we can't keep adding. So that's a real challenge for all of us. Finally, I'd like to make a pitch for a commitment to flexible thinking. This is Adam Grant again, his latest book. Very, very nice piece of work. And again, he's got some nice TED Talks as well. But he points out that, as he quotes from George Bernard Shaw, progress is impossible without change, and those who cannot change their minds cannot change anything. So I think that as we look forward to a proactive approach to responding, to being ready for the next crisis, to continuously improve, being able to change our minds, being able to reconsider our closely held beliefs is going to be an invaluable attribute. So, in summary, the reaction to the pandemic crisis was limited by connectivity issues, some online design issues. I think we should include the concept of trust when we teach social determinants of health. I completely agree with the other speakers that developing leadership skills in anticipation of change is essential, and I would argue that those leadership skills need to be taught to a fairly broad sampling of our institutional ecosystem. I think we need to continuously evaluate curriculum content. I think we need to move from a sort of a summative to a formative model for program evaluation. I do think we need to focus on our delivery systems. Those of us that have it think it's great, but talk to some who don't, and they'll give you all of the examples of how they were cut off or how the electricity went out. And I think we as institutions have a responsibility to work with other sectors to make that better. And keeping in mind that we have explored extensively this new world of what Dr. Rani called digital medicine. And I think we need to reconsider what we're doing in the classroom. And it's not just a matter of the flipped classroom, but it's also a matter of the global flipped classroom. And then just when you are sure you already know whatever it is you think you know, remember to think again. So I'll just say, Shakran, thank you, and I'll be happy to address any of your questions. Thanks very much.
Thank you. Thank you, Professor Burdek, for your nice presentation and also for saving some time, because we are almost behind the schedule, so we have to move forward for the third speaker, Professor Khan. Professor Yawad Hayat Khan. He is a professor and dentist. He got his master degree in health professions education from Maastricht, and currently he is a professor and head of the department as well as assistant dean of medical education at Rifah University and administrator of the dental hospital. He is interested in areas like leadership and management, curriculum development and patient safety, etc. His talk today about the future healthcare leadership, the four pillars. Please, Professor Khan.
Thank you very much, Professor. I hope my slides are visible.
Yes.
Bismillahirrahmanirrahim.
Clear.
Thank you. The topic for today's presentation is future healthcare leadership, the four pillars. First and foremost, I would like to thank the management of this prestigious conference, Summit 2022, SSME, and all the stakeholders for having me over, inviting me to this prestigious event. I'm honored. And I also wanted to share that, let me share with you very frankly that it's very hard to be the last speaker of the conference, especially when it's a long day. And also when you are speaking after two wonderful speakers, my dear friends, Professor Gary and Professor Burdek. So I try to keep my presentation a bit simple, and I will just discuss quickly the daily issues and challenges faced by healthcare leadership, and also different barriers and challenges. And then at the end, I will sum up with the four pillars of the healthcare leadership. I dedicate my presentation to my parents, my family, and my teachers. So I have already been introduced, so I won't waste time in introduction again. The aim of the presentation is to familiarize the audience with the roles and responsibilities of the modern day healthcare leadership in achieving excellence through different strategies and steps. And as I mentioned, I will also highlight a few challenges which healthcare leaders they face. And last but not the least, the importance of the four pillars laying down the foundation of future healthcare leadership. So these are a few objectives of my presentation, which I'll be giving right now. Excellence is not a skill, it's an attitude. And some people also say that strive for excellence, not perfection. Yeah. And excellence is the gradual result of always striving to to do better and also the best. So if we define excellence, we can say that it is the quality of being outstanding or extremely good. When we talk about organizational excellence, we mean quality, capability, and maturity of delivering outstanding or extremely good deliverables. So let's go to excellence in healthcare. Healthcare industry is expected to deliver a collective effort and excellent services and products to the community. When we talk about excellence in healthcare, we mean providing a value-based healthcare. And achieving excellence means that if a healthcare setting, it continues to achieve its operating objectives and fulfill all its missions over the long term and is also resilient over time, we say the organization is excellent in delivering. Why excellence is important? There are many reasons to constantly improve the quality of care and ensuring that healthcare providers, they are up to date with the latest evidence-based interventions. It also means that the healthcare providers needs to be the positive forces for change. They are the change agents, especially in the lives of patients, by listening carefully. Very important skill, as mentioned by my other dear colleagues as well, that a leader has to be a good listener. And clinical excellence is about achieving consistently in the way care is delivered. The question arises why there is a need for pursuit of excellence in healthcare. I guess the culture of excellence opens path to success. There are many challenges in the healthcare system today, which has left many of us feeling defeated. And there are daily challenges. There are new and formidable challenges at day-to-day basis we face as healthcare leaders. And only those who strive for excellence will be able to lead us to solutions that will create the quality of healthcare. So the question arises for healthcare organizations that why excellence and why now? So first is our survival is under threat. We know it's a time of competition. There are many competitors out there. So if we need to survive, we need to be excellent, of course. And secondly, as I said, it's an era of complexity, it's an era of competition. So we have to compete with all our colleagues, our collaborators, competitors, whatever you say. Question comes, what is a healthcare organization? It's very much, as you can see from the diagram, the healthcare organizations are complex organizations. And when we define them, we call them complex adaptive systems. They are basically today's healthcare organizations. Quickly highlighting a few healthcare issues in Pakistan. We have a critical shortage of health service providers over there. Unfortunately, weak regulatory frameworks, political interference, very unfortunate, gap between medical training and ongoing on-ground issues, and lack of effectively functioning preventive healthcare systems. The stakeholders of healthcare delivery system, basically, I have classified them under the three domains. We have external stakeholders, we have the interface stakeholders, and we have the internal stakeholders. When we talk about external stakeholders, we have suppliers, patients, and the financial community, and these are those stakeholders which provide input to the organization. Then we have other organizations which are basically our direct competitors for patients or for skilled personnel, and C, the government regulatory agencies, private accrediting associations, professional associations, and other political action groups. So these all are categorized under external stakeholders. When we talk about interface stakeholders, they include board of trustees, board of governors, and medical staff, and they basically function on the interface between the organization and the environment. And third are the internal stakeholders, which basically we all belong to this category mostly, most of us, management, professional staff, non-professional staff, and these are the people who basically they refer to the overall performance and measures organizational effectiveness. So what makes a good healthcare system? A good healthcare system is the one which covers broad range of services, provides innovative care, patient-centered, have strong regulatory frameworks, a strong culture based on collegiality and respect rather than a culture of blames, and a culture of excellence with a commitment to fulfill organizations' missions and visions. So coming back to today's healthcare system, so I think we must agree on this, that in today's healthcare systems we have had problems, all of us. And if I quickly point out to these problems, we have personality clashes, we have reduced innovations and new ideas, organizational challenges, blame culture, leadership priorities are different, engagement lack between different stakeholders, medical errors, and seriously compromised safety and quality. So these all are the problems of today's healthcare. So what the future healthcare should look like? Future healthcare should have solutions. We assume that they have solutions. And what are the solutions? Solutions are safe healthcare through holistic approach, opportunities for collaboration and awareness. The focus of leadership should be to engage all the stakeholders, understand patients' perspectives, involve patients as their partners. Team-based approach should focus on integration of efficient technology, obliging attitudes, discouraging blame culture, should introduce new innovations, and also establishment of sustainable safety cultures. So these are the solutions which we look towards the future healthcare systems. Definitely, as we see, there's a definitive paradigm shift, and time is getting changed. Now we have seen, courtesy of this pandemic as well, that things are changing from face-to-face to blended learning, hybrid models, physician-centered care to patient-centered care, and so things are changing. So it's up to us to realize this change. So are we ignoring the warning signs? Are we not aware of the danger around us? And it's up to the leadership. It's up to us, the healthcare leaders. How do we see our organizations? Do we want to stick to the old methods, the old procedures, and the old tricks, or we want to adopt some new methodologies and we want to go towards some new innovations? It depends upon us. And mostly it depends upon healthcare leadership. The healthcare leadership is responsible for all these changes to make. And if we just quickly see, if in a glance, healthcare leadership is to be in charge, is certainly not only to carry out the proper measures yourself, but to see that everyone else does so too. It's about empowerment. It's about listening. It's about delegation. It's not about growing yourself, it's about growing others. And it is this leadership which is required to tackle the complex, dynamic, and changing healthcare environment in order to keep the healthcare organizations effective, sustainable, and successful. And if we broadly look at the healthcare leadership umbrella, we have 4 types of leadership domains inside that umbrella. We have organizational leadership, top management. We have educational leadership, the educational leaders, the healthcare leaders. We have clinical leadership, our clinicians, our physicians, staff working in the hospitals, and also we have student leaderships, the students which are working, one of the very important stakeholders of healthcare leadership umbrella as well. And why this healthcare leadership is important? It's important because valuable leadership skills makes a quantifiable difference in patient care. Quality in healthcare operations and employee management creates a culture of trust, confidence, and loyalty amongst all the stakeholders. And it is essential in order to cope up with the ever-changing demands of the healthcare settings. Effective management is required to facilitate change and achieve results through ensuring efficient mobilization and utilization of workforce and other resources. Last but not the least, healthcare leadership and workforce management, they are interlinked, and I think they play a critical role in the healthcare delivery system. Quickly mentioning about the role of healthcare leadership in Pakistan to improving healthcare. Rifa University has been instrumental in improving healthcare in Pakistan. We have established a Rifa Institute of Healthcare Improvement and Safety in 2016. We organize annual conferences highlighting patient safety, medical education. We have developed and implemented undergraduate curriculums, patient safety curriculums for pharmaceutical sciences, rehab sciences, and dental sciences. We have had our healthcare curricula transformed from traditional to integrated and outcome-based curricula. And also we are focusing on planning to hold practical trainings and assessment workshops for JCI, Canadian accreditation, and other prestigious accreditations around the globe. So the key responsibilities of healthcare leadership are to formulate effective healthcare teams, effective decision making, critical risk management, clinical governance, quality standards, and patient safety protocols. These are the key responsibilities. I'll just quickly go through the slides. I will not go into the detail because I know time is short. So first of all, I said formulate healthcare teams. It's very important to have healthcare teams in place, effective healthcare teams, of course, to have proper healthcare team members assigning right person for the right job. And we know no one can do everything, but everyone can do something. So it's very important for a team to have good teamwork. Decision making, as I said, both decision making are important, clinical decision making as well as business decision making. So academic leadership and business leadership together. Risk management is also very important. Risk could be anything related to patients, related to staff, related to employees, property, or other financial risks or any other risks which the healthcare organization faces today. Clinical governance is also very important. I must say it's a key for the clinical leadership to have in place. And you can very well see the comparison of organizations which have clinical governance and which don't have clinical governance. Quality standards, of course, we all know a lot of things have been said about having good quality standards, and it is very important for healthcare organizations to lay solid foundations in terms of quality and also in terms of patient safety protocols. So quality and patient safety, of course, they are of the need to be implemented and inculcated in the systems of our organizations. They're also important because the patient will never care how much you know until they know how much you care. So these all principles, they are now patient-centered. They have shifted from the physician-centeredness towards patient-centeredness. What should be the desired qualities of healthcare leadership? Students, colleagues, sometimes the students ask us, what are the desired qualities? There are many qualities, but I think a few of the qualities mentioned by Professor Burdek as well, and some other colleagues also, that setting the direction for others to follow. There's a culture of praise should be there, visionary leadership, share the vision. Just saw a very beautiful slide that if the vision is under-communicated, it creates a lot of problems. So vision should be shared properly. Motivate employees, authentic and credible leadership, develop a true team environment, share responsibility, and empowering others. These are a few desirable qualities in healthcare leadership.
3
Then
minutes.
I'll just quickly go through a few steps of achieving healthcare excellence. I'll just name the steps. Let's go through them. Motivation is the key. Exploring your strengths, focusing on your goal. You should be goal focused. Be realistic. There should be realistic goals, not just, goals in the air. Time management is very important. One has to be obsessed with one's goals. The organization should be obsessed with the goals if they want to achieve them. Perfection and excellence. Teamwork. Then sticking to the ambition, making you authentic and credible. Creativity and innovation. Clearly identified objectives, very important. Plan sustainable strategies. Humility, patience, and last but not the least, they should never lose hope. So after the steps, I'll quickly share with you the few important strategies which are important in achieving healthcare excellence. Just the names. although we can talk about them in maybe some other setting. But just quickly to name them: change management in healthcare, uh, creating a holistic model of healthcare, patient-centered approach, a salutogenic approach in healthcare, very important, a team-based approach in healthcare, and last but not the least, a systems approach in healthcare. So coming to the challenges, after the steps and the strategies, coming to the challenges, what shifts do healthcare leaders need to prepare for? And if we go local, from global to local, if I talk about my organization, we have got, and more or less different organizations I've visited and I've come across more or less face the same challenges. There are organizational structure challenges, conflicts in coordination, authoritative challenges, financial resources. There are human resource challenges, short of manpower, conflicts in the workplace, inadequate training. There are work-related challenges as well. High workloads, rotation of working hours, decreased mutual communication between the stakeholders. We have context-related challenges as well, cultural challenges, poor teamwork, lack of motivation, lack of communication, lack of mutual trust. Trust is very important, as Professor Burdek very rightly said. And also we have leadership-related challenges. If leadership is not focused on what to achieve, what is the priority, lack of training of senior managers, lack of support from the senior management, strict regulatory environment, and also cybersecurity. So these are
Could you conclude, Prof. Khan?
So coming towards the end, last few slides. If we say what is the recipe for successful healthcare leadership, I think there are 5 leadership principles in the recipe. Continuous learning, establishment clarity around the set of values, communicating a clear sense of purpose and vision, building a culture of excellence and accountability, and creating a culture that emphasizes the development of leaders and leadership. If we look at today's healthcare from 2050, we can say that the future healthcare leadership, there are 4 pillars of this future healthcare leadership: hospital management, clinicians, patients, and students. So hospital management, the first important pillar, which allows the structured functioning of healthcare. It involves planning, organizing, leading, coordinating, and control with sustainable solutions, inculcating and having state-of-the-art technology, telemedicine, and things like artificial intelligence. Second pillar of the future healthcare leadership are basically our clinicians, the healthcare delivery providers, and they are the facilitators. They're no more healthcare providers, they're facilitators, they're educators. They educate patients, families, they involve students in teaching, educate students as well, and they help improving access of healthcare delivery with innovative ideas. The third pillar are patients, which were neglected in the past, and in future patients are considered as partners in healthcare delivery, and we know the importance of patient safety and quality, some important initiatives like patients as partners in healthcare. So patients are a very important pillar of this future healthcare leadership. They are the advocates of health and healthcare delivery systems. Last but not the least, the fourth pillar are students, the integral stakeholders, which are responsible to increase patient satisfaction, which improve patient care, and it can be done with care coordination and proper planning, and also if they are equipped with latest technology and competencies. So the foundation of future healthcare leadership is laid on these 4 important pillars. And the power of change lies in collaboration between these 4 pillars. It's up to us, the leadership, to collaborate for a better future, to collaborate for a better world. And they say, if you want to go fast, go alone, and if you want to go far, go together. And it is also said that when I is replaced with we, even illness becomes wellness. So I think it's about teamwork. It's about coming together. So the take-home message for today is, let's go and build stronger teams. Let's go and build stronger communities. To conclude, I must say that if you want to succeed, if you want to go into our future with sustainable ideas, we must understand that the road to success is always under construction. It's never over. You have to make continuous improvements every day in your routine day-to-day systems, and this is how you achieve excellence. So this is my email address.
Thank you.
If anybody wants to comment, suggest anything, you're more than welcome. I thank you all for your patience. Thank you very much.
Thank you, Prof. Khan. We have to break for the Maghrib prayer. But before we break, I think we don't have time for questions. I will let Dr. Hassan to
Okay. Thank you,
close.
Professor Khalid.
Yeah.
Thank you very much for our three speakers, Professor Sayed Gari, Professor Burdek, Professor Khan. It was really a fascinating session. Sorry for not receiving questions now because we have already behind the schedule. And at the end of and before we leave you, we would like, we hope that to see you, all of you, in person in Saudi Arabia in the near future, inshallah, in the coming meetings. Thank you all for joining CIMIC 2022. And again, hope to see you soon in person. At the end of this session,